Okay, good morning. Oh, it works. It works. We're very excited. Good morning, everyone, and welcome to the Women's Society of Washington University's December lecture. We're so sorry for those technical difficulties. Seems like it's the holidays, so we'll have some delays. But thank you all for taking the time to join us. We're thrilled to see so many of you here this morning, also joining us online via our live stream. We're sorry for a little bit for the late start, but we're so happy to have Dr. Khabele here with us this morning. I want to give a special welcome to our guests. Also, I don't want to miss this opportunity to remind you that you can join the Women's Society, and there was a code up on the screen, but you can find it at the registration desk. We welcome you to come and listen to all our wonderful faculty members for our lecture series throughout the upcoming year. We're an organization that was created to bring the community to the university and the university to the community. We're a group of volunteers of all ages and backgrounds that are interested in supporting Washington University and realize the valuable asset it is to our community. We're proud partners in supporting Chancellor Martin's vision for Washington University to be in St. Louis and also for St. Louis. If you're not already a member, be sure and look for that code. And we also want to remind you about our Bare Necessities shop that's located here on campus, where you can get all your WashU logo apparel. All the proceeds support our scholarship fund, the Elizabeth Gray Danforth Scholarship Fund. This has already been a very exciting year at Women's Society, and it's my pleasure to turn things over to Aixa Martinez, who will introduce our speaker. I'm grateful for her leadership. And I just want to remind everyone that if you have questions, please hold them until the end so we can get all the information from Dr. Khabele in the beginning. So thank you and welcome, Aixa.
Thank you, Angie. Good morning to all of you joining us today. I am Aixa Martinez, and I'm pleased to introduce today's speaker, Dr. Dineo Khabele. Dr. Khabele is the Mitchell Elaine Yanow Professor and Chair of the Department of Obstetrics and Gynecology at Washington University School of Medicine in St. Louis. She is a recognized physician scientist with extensive clinical and translational research experience in gynecologic oncology, with a focus on ovarian cancer. Dr. Khabele's ovarian cancer research is funded by the National Institutes of Health National Cancer Institute. Her ovarian cancer research interests include chemotherapy resistance, DNA repair, epigenetic targets for therapy, and targeting the tumor's environment. She's a dedicated educator and mentor to students, residents, fellows, and faculty. She's an advocate for women's health, women's cancer, and health equity. Dr. Khabele's board is board certified in obstetrics and gynecology and gynecologic oncology. She obtained undergraduate and medical degrees from Columbia College and Columbia College of Physicians and Surgeons at Columbia University in New York. She completed her residency in obstetrics and gynecology at the New York Presbyterian Hospital, Weill Cornell University Medical Center, followed by a clinical fellowship in gynecologic oncology, and postdoctoral research training in cancer biology at Albert Einstein College of Medicine and Montefiore Medical Center. She was a scholar of the Reproductive Scientist Development Program and of the Amos Medical Faculty Development Program. Washington University is fortunate to benefit from her expertise, and we are grateful to have her here with us today. Please join me in welcoming Dr. Khabele.
Thank you. Thank you so much. Thank you. First of all, I want to thank the Women's Society at Washington University for this wonderful invitation. I'm really happy to be here. Thank you for that really kind introduction. And what I normally do when I start a talk is to give sort of a reverse history, because I think it explains who I am and why I'm here. So I've been at Washington University in St. Louis since June of 2020. So does anybody recall what was happening around June of 2020? What a wonderful time to start a job. So I started in June 1st of 2020 in the middle of another big surge in the COVID pandemic, the global pandemic. This was 2 weeks approximately after George Floyd had been murdered, and there were protests and curfews in St. Louis. The house that we purchased on Lindell was not ready, so I stayed in one of those extended stay motels or hotels, and there was no food. So remember, curfew, and so they had these little, like frozen dinner kind of things. And I remember I got one, I put one in the microwave, turned the news on, and there was a 7-Eleven burning. They're like, 7-Eleven's on fire, because I just sat on the edge of the bed going, what have I done? So that was a great way to start. But I'll let you know that the reason I'm here is in part because I was drawn to this high-level strategic vision expressed so nicely by Chancellor Martin and by the people I've met along the way, that this esteemed university, Washington University in St. Louis, is not just about being a powerhouse academic medical center or academic university and establishment, but it is for St. Louis, and this is an opportunity for us to lead from the heartland, from the middle of the country. Because some of the issues that I've just mentioned, global pandemic, racial unrest, reproductive health, if we can solve some of these problems in St. Louis for St. Louis, imagine what a model we could be for the rest of the country and the world. So that's sort of why I'm here. But how I got here is I was the division chief for gynecologic oncology at University of Kansas in Kansas City on the Kansas side. And I'd been there about 3.5 years, started a fellowship program, was running my lab, and really trying to make a difference in women's health through women's cancers. You have to understand that in our research funding through the National Institutes of Health, the fraction of funding that goes to women's health is so tiny. So the fact that last week, the President of the United States, President Biden, and First Lady Dr. Jill Biden had this big initiative to really refocus us on women's health research is monumental. Because you cannot assume that if we are going to give a person a pill for hypertension, that it's going to work the same. If you're 6'5" and a big 200-something pound man and a 5 foot, 110-pound woman, we can't assume that. We can't assume that the same things are going to work with all of the wiring we have internally, the different hormones, the different proteins that are expressed based on biological sex. We can't assume that the stressors of society are going to be the same because we know that there are differences in how we experience the world and how the world experiences us based on so many things that are social constructs but do make a difference. So I'll come back to my story here of my journey was at University of Kansas to make a difference for gynecologic oncology. We started a gynecologic oncology training fellowship program. It was the first accredited gyne fellowship in the state of Kansas that has women's health deserts and healthcare deserts. Before that, I was at Vanderbilt University in Nashville, Tennessee. And I was there for about 9 years and started an ovarian cancer lab that we partnered with people who were survivors and advocates of ovarian cancer. And we called the group VOCAL, Vanderbilt Ovarian Cancer Alliance. And so we had people who were survivors and advocates actually come on campus and have lab meetings with us. So they understood what we were doing in the lab and would help spread the word about the importance of what we were doing. Prior to Vanderbilt, where I did research and I was a surgeon and gave chemotherapy, I was at Meharry Medical College. Meharry Medical College is one of the 4 historically Black medical schools in the United States. And I was recruited there in 2004 to help them restart their OBGYN residency. They did not have an OBGYN residency for approximately 12 years. And what's really important is the people we recruited went back home to their communities to serve them. So You're going to hear a theme about OBGYN deserts, women's health deserts, lack of research funding, lack of funding. And some of the solutions are in places like Meharry Medical College that trains people who come from a small town in rural Mississippi who want to go back home to help. So I'm very proud of the fact that a bunch of us were recruited to Meharry Medical College. We graduated our 4 residents. I saw them through 4 years from interns to chief residents. They all graduated, passed their boards, and went back to their communities to serve. And then before that, I was a New Yorker for about 20 years. Before Meharry Medical College, all my training was in New York, and you heard about that. But part of that experience in New York, I arrived in New York in 1985, and that was at the height of another epidemic. That was the height of the HIV/AIDS epidemic, and the height of the beginnings of the crack cocaine epidemic. And so, these little points in time and history have definitely influenced my view of what I'm doing in healthcare and why I wanted to be a doctor. And originally, I was a very active political scientist, very active in women's health advocacy, really was exposed to a lot of gay rights advocacy, joined the Black Women's Health Project in college, which is now the Black Women's Health Initiative, which really created self-help groups in the community for people to educate each other about important things like menstrual cycle and menopause and childbirth. And through that experience, I thought I wanted to be a midwife. And I actually met a few midwives in Harlem, New York. And one of them took me aside and said, you actually have a chance to go to medical school. I didn't. So why don't you go to medical school and take midwife sensibilities with you, right? So these are places in my history that have influenced why I'm so passionate about what I do in women's health. So I'm going to fast forward back to the present day. Pandemic, racial unrest, and then we have the Dobbs decision. So Missouri was the first state to enact its trigger law to restrict abortion care in the state. And the impact that has had on us in women's health care is profound. First of all, at Washington University and Barnes-Jewish Hospital, we were pretty much the only place left standing to provide this care. And we actually still provide care to save the life of the mother. We are still providing abortion care to save the life of the mother because that is the law of the state. But what it has done is it has created an environment where regular, routine reproductive health care, people are afraid to give it. So in certain parts of the state, people are afraid to provide birth control pills or insert an intrauterine device, an IUD, which is birth control. It's not an abortifacient. People are afraid to help somebody who's having a spontaneous miscarriage. We have medications for that help stop the bleeding, help pass the non-viable pregnancy, and help save a woman's life if she's bleeding out. People are afraid to perform DNCs, which to evacuate the uterus. And so what's happening is we're getting all these patients coming to us where we're willing to perform these procedures. But can I tell you what that's doing to our workforce? What that's doing to our trainees, our residents, our fellows, the faculty on staff at Washington University? It is very, very tough. And so part of what I'm doing here is to provide some education about sort of the landscape, how we're trying to address it, and really it's a plea for help in helping to educate the community as to what exactly these laws end up doing. When I think about women's health and women's health care, I want all of us to think about and reflect for a moment, just quietly, what your own personal experiences have been in interfacing with healthcare. Our healthcare systems right now are under so much strain, and we feel it as patients. So not only am I standing in front of you as a physician and as a scientist, but I'm also a patient, right? And every single one of us has been or will be a patient one day. So how do we create a healthcare environment so that when we enter the walls of a clinic or a hospital, we are made to feel like people care about us, not just that we are a consumer or a customer or a widget. That is really, really, so pile on top of all these other things, this is what we have to wrestle with as healthcare providers, as physicians, as nurses, as people in healthcare. How do we show up to provide, really compassionate care? And I tell the story, and I've written about it, about my own experience. I have one child, and I delivered my child in the hospital where I trained many years later from the time that I graduated. And I'm going to pause for a moment and tell you, and just my disclaimers, I tell a lot of personal stories, not to brag or not to say I'm all that, but just as examples to hopefully inspire people to also tell their stories, but also to connect with people, because if you've delivered a baby, you know what I'm talking about. You know what a labor pain feels like. And I was an OBGYN. It shocked me. I found it indigestion. So it helps to be a patient if you're a physician, because sometimes you can really relate. But one of the things is that I've written about this. I arrive at the hospital. I check in. My last name is different from my husband. So Dineo Khabele, James Hunter. I was in labor, so I had my overalls on, and I'm in pain. So I'm kind of shuffling in to check in. And they immediately see my hair like this. I'm with my husband. He's a different last name than me, so he must be the baby daddy. And our address is in Harlem. So immediately, so drug tested, drug screened, sat in a corner because they didn't believe I was really in labor. And so I knew, my husband knew I was really in pain because I got quiet. And so he ended up doing a lot of advocating for me. I tell this story because as a Black man at Columbia University, I'm on their alumni board. I love Columbia University, but if this is my experience, imagine the experience of people who are not physicians. And so he had to advocate for me, but he had to do it quietly. Because God forbid he raises his voice, what's going to happen to him? Right. So quietly, he asks to call Hilda Hutcherson, who was my mentor in medical school, happened to be my doctor. This was the night before Thanksgiving. She wasn't on call. So I overheard him. I was like, no, don't call her. She's not on call. Right? They called her anyway. And do you know what? She came in, everything changed. Because Hilda Hutcherson happened to be the associate dean. Hilda Hutcherson happened to be very prominent. She was also a Black woman, but she happened to be well known. Comes in, everything changed. And so that story is not because, I know Hilda Hutcherson. That story is, if this is happening to me, can you imagine what happens to other folks? So I'm going to bring that story back to St. Louis. When I first made my rounds on labor delivery at Parkview Tower at Barnes Jewish Hospital, people don't know how gorgeous Parkview Tower is. People think of Barnes and big Barnes and think of the old maternity. Most people don't know what our labor and delivery unit looks like when you think about delivering at our hospital. I can guarantee. And you walk onto labor and delivery when I made my first rounds, and I was blown away. You walk into our Women's Assessment Center, state-of-the-art ultrasound, equipment, everything you could possibly want. Labor and delivery, all private rooms, many of them facing Forest Park. The central hub with nurses and doctors working together. Everybody's monitoring in real time what's happening in rooms. You can bring your family with you. It's very family centric. You can have a doula with you, a birth partner with you. And the best part of it is, if there's a problem, there's a bridge that takes your baby immediately to St. Louis Children's Hospital, and it connects to their neonatal intensive care unit. It's the highest level of care, and so I told the first part of my story to let you know I've worked in many different places in the country. state-of-the-art institutions. And this is a state-of-the-art institution that's the best kept secret in St. Louis. So people will drive from Illinois past us to deliver at Mercy or Mobile. I know this, I've learned this now. And so it's a fascinating kind of social story. But the physical plant doesn't take away the history. The physical plant doesn't erase the fact that we've not had a good history. So if you talk to some of the people I've talked to from North St. Louis, they recall days when they were not admitted to the main part of Barnes or Jewish, that they had to deliver in the basement of these hospitals. And that they may have had their lives saved and their babies delivered and their surgeries performed, but they lived to tell the tale that they did not like how we made them feel. And so part of women's health is not just about women's health, it's about health and healthcare. We can't have all these fancy gadgets and all this technology and all these advancements if they're not going to help everybody. And I'll come back to the importance of women's health, because if you have a terrible experience in pregnancy and in labor in a healthcare system, do you think you're going to let anybody else in your family go back? Because women are the caretakers of not only their immediate unit, but what are they doing? They're taking care of their parents. They're taking care of their grandparents. They're taking care of their husbands. You got to go get your PSA checked. You know, like they're the people who are navigating all of this for their entire family. And I make the case in board meetings and in corporate kind of environments that we keep missing the mark. If we don't really understand that we have to talk to women about their experiences and what they need in healthcare, we're going to end up losing, because, you know, women are the main drivers of where you go to get your health. Where are you going to take your kid? Who are the pediatricians that I'm going to trust? And so if we show that, there's a business case for it. There's also, I hope, I've tried to make kind of a moral and ethical case for why we have to show that we care and not just perform surgeries and do deliveries without that other piece. The state of Missouri is in a crisis for women's health care. 47% of our counties have no maternity services, no obstetrics. 47%, that's almost 50% of the state, doesn't have access to proper obstetrical care. So what happens is many women don't even know they're pregnant. They're not getting early prenatal care until very late in the process. Lots of people are coming to us with high-risk pregnancies. So that's the specialty of maternal fetal medicine. And we can't get enough maternal fetal medicine specialists. I mean, we keep hiring, still not enough, because we're taking care of people who have such high-risk pregnancies, from high blood pressure, hypertension crises, cardiovascular disease. We're seeing young patients with heart failure. We're seeing patients who have infectious diseases. We took care of so many pregnant patients during the height of the COVID pandemic. Many of them who survived, but we have all these sophisticated technologies like ECMO. We're bypassing heart and lung bypass to keep people alive. We need to be able to recruit maternal fetal medicine specialists to the state, but we can't have them driving all over the place. So what we're trying to do using technology is create virtual monitoring, and we've started that process. So we're offering virtual ultrasound monitoring as far east as Carbondale, Illinois, and we're starting to talk to people in Cape Girardeau region, Rolla, and moving west. because if we can make these diagnoses, we can then help inform whoever's in that region, whether you're a family practice practitioner, nurse practitioner, taking care of that patient, and then we can help triage and say, well, this type of patient really does need to make the 3-hour drive to come see us so we can do more testing, or they may have to be transported here once they go into labor, or this type of patient is really, you're perfectly capable of taking care of this patient, keeping her closer to home. That's the kind of technology that we want to offer in remote monitoring for ultrasound and remote consultation. So we have Zoom, we have this hybrid room. This is beyond just Zoom with the patient. This is a higher level of telemedicine with the providers and the hospital systems to fill this gap. The other thing that we're really interested in is technology to diagnose high-risk pregnancies. And I'm going to shift gears a little bit to talk about some of the research that's happening in our department. So one of the big projects we have is, and COVID helped us with this project, and we had wonderful donations from donors to help us with this. If you have high blood pressure in pregnancy, you need to be monitored. And we were restricting people coming in and out of the hospital. So could we do remote monitoring? So you just check your blood pressure at home and then you communicate with us and we tell you when you absolutely have to come in, but most of the time we can adjust your medicine and you can stay home and be safe. A lot of our patients didn't have blood pressure cuffs and didn't have access to them. Through generous donations to help us with this and through our BJ Foundation, and this has helped us provide our patients with this ability. And that's turned into a research project to see if we could do this and expand this to other areas. So that's an example of remote monitoring directly with the patient. We're studying sleep and remote monitoring circadian rhythm. During pregnancy, it gets a little bit off, and helping people monitor that and trying to find interventions for that. We have an amazing biomedical engineer, Dr. Yang Wang, in our department. He's a PhD, and he asked a very important question. So with heart disease, we have an electrocardiogram for the heart. So we can look at electrical fire in the heart. We call it an ECG. The uterus is a muscle, and it has electrical conduct through the muscle to help it fire during labor. Does anybody know anything about that? How that works? How do we monitor it? Well, we put these little monitors on the outside and we infer how the uterus is contracting. Well, he said, well, couldn't we combine electrophysiology, what we do for the heart, and apply it to the uterus with imaging? So he's created this product called EMI. So it's electrophysiology monitoring with MRI of what's happening in labor. So if you really understand what's happening to the uterus in labor, maybe you can prevent preterm labor, or you can help somebody whose labor is not going very well. We only have one drug that we use right now, oxytocin, to help labor progress in the middle of it. How do we better understand that? So there's an entire lab in our department that's looking at oxytocin and the receptors and figuring out what they're actually doing. We have the drugs, the pitocin we call it, that we give people in labor, but do we really, really understand how it works? Have we invested in this question? Who's asking these questions? And it wouldn't have occurred to people in previous years if you didn't have the right type of researchers who are interested in asking these questions. So another big important research initiative is not just in the lab, but also in the clinic. One of our researchers, Dr. Ebony Carter, has done really well, and she's actually left WashU to be the division chief for MFM at University of North Carolina in Chapel Hill. But her research remains, and we're really very connected with her work. But she asked the question about group prenatal care. You know, if we don't have enough providers, if we don't have a huge workforce, can we get people in a group prenatal care setting, give everybody the same information, and then create these peer pods, this peer self-help group to help during pregnancy? And the initial research showed that group prenatal care really didn't make much of a difference for most people except Black women. Black women who were in prenatal care, we found, had fewer preterm births And she's actually has this huge initiative. We're in the middle of a big NIH study looking at group prenatal care to prevent postpartum depression and behavioral health problems after delivery. So stay tuned for that. In addition, we have research looking at substance use disorders, and many people who are pregnant are, use or are addicted to a variety of substances. And just because they have that issue or that condition doesn't mean that they don't deserve care. So in partnership with BJ Hospital, BJH, and the foundation, we have a care clinic where we actually are able to take care of patients throughout their pregnancy, and many of them are able to continue with treatment and keep their babies. I told you about 1985 and HIV/AIDS and the crack epidemic, and a lot of lessons, a lot of history keeps rhyming and sort of repeating. But at the height of the crack epidemic, we separated babies from their mothers. So I remember rounding in the hospital, and they would have just these entire pediatric wards of just babies, and they were just crying. And for some reason, we were told that they didn't want to be touched because they were so sensitive, because they had been addicted to cocaine, and they're, so these are babies in these little bassinets just crying. So fast forward a couple of decades, and we found out, looking back, we probably shouldn't have separated those babies from their moms. Actually, the moms needed treatment, and the babies needed to be with their moms. And so hopefully we've learned a few lessons from that, and that's our approach now. If we can help it, we try to keep babies with their mothers. The other thing that we learned is just the impact of isolation. So when I was a medical student, we were rounding, I did my internal medicine rotation at Roosevelt Hospital, which was downtown New York, Midtown. It's now closed. But our entire ward was filled with men primarily who had been abandoned by their families, and they were in the hospital, complications secondary to AIDS. And we were their family. We were their family because they didn't have people to be with them. Many of them died. And so in 2020 and 2021, when we had so many people in the hospital who were alone, and many people died, the healthcare workers were their family. The doctors and the nurses, the residents, the fellows, the janitors, the food workers were their family. And so, I've given you these little vignettes to sort of expose pieces of my brain to why I'm here and why I'm so passionate about what I do, why WashU is the place for me to be at this place and time, understanding all the resources we have, all the talent we have to make a difference, not just in St. Louis, for St. Louis, but for the country. We've lobbied really hard as individuals in the past few years to get Medicaid expansion for our patients. We lobbied really hard this year to get postpartum care to be extended to 12 months instead of 6 weeks, and that just passed. We lobby every day for our patients for reproductive care, the entire continuum, from pediatric care all the way to menopause. And we also need to understand that we're doing a lot of work on ourselves so that we can be better servants of this care. That we're not just surgeons, we're not just physicians prescribing medications, but that we show that we truly care about our patients in front of us and our community. So I did want to leave some time for questions, but I hope I've been able to describe my purpose and how it's so very much aligned with what we're doing here at WashU. And I'm going to end with a call to action that hopefully you got something out of this, even one small piece of it, and that you'll spread the word of how important women's health care, reproductive health care is, not just to us here, but to our entire community. So thank you.
few minutes for questions.
So one question that I had already had in my head, and that it might relate to that study you did about the prenatal group care. I'm curious if you have theories on why it only was effective with the Black women, and separately, I've read about how Black women of all socioeconomic backgrounds have worse pregnancy outcomes than white women, and curious about what drives that, and if there's any research going on about that.
Well, so to repeat your question, the question is, do we have any theories about why the group prenatal care seems to work for Black women and not others? Is the first part of your question. The second part is understanding that there's lots of research that's already been published that it doesn't matter socioeconomic status, education, whatever your background, that you have worse outcomes if you're a Black woman in pregnancy outcomes.
Why is that?
And why is that? So that's a very complex question. We're starting first with the first part. I think part of it is what I talked about a little bit from my experience in college and those self-help groups, like the Black Women's Health Project. So you're getting your information from trusted sources, and you're sharing common experiences and then best practices amongst each other, and you're made to feel safe. I think that sense of safety and lack of fear, I think, goes a very, very long way. What's interesting is we have a sub-project where we're looking at the impact on the healthcare providers of having this group prenatal care. And one small vignette is that, somebody gets very frustrated. You were 15 minutes late for your prenatal visit. Don't you care about your baby? Well, the person had to take 2 buses and walk whatever to get here, and the bus was late. So when you're in group prenatal care, then somebody says, well, I live in that same neighborhood, and the bus never comes on time. And so what is that doing to the provider to then hear this over and over again? That's not the patient's trying to ruin your day, but this is a structural problem that happens for patients coming from that particular neighborhood. And so can you soften your stance if you're hearing this? They're not trying to offend you. They're just, this is the reality of where they live. That's one piece of it. And then we just have a lot of work to do to overcome biases, to overcome just people's impression. I mean, every day this happens. People assume because somebody looks a certain way that they don't have insurance, and because they don't have insurance, they're going to be treated a certain way. Like, we have to get rid of some of this stuff. And that's really harder to study and harder to unpack. Because I think that requires some deep reflection and really people talking about some very hard topics. So, but thank you.
What can we do besides spread the word?
Well, I mean, if you are really interested in reproductive health care, I think we have to vote. I think we have to understand what's at stake. This is me talking personally at this moment, not on behalf of the university, but I gotta say, it makes a big difference. And so those are the two things that I would say. I think also putting pressure on our own congresspeople, because there are some things that are bipartisan. Cancer, everybody's affected by cancer. Everybody's affected by pregnancy. So we were able to get things like extending postpartum care through because that's something that people could relate to, so I think that those kinds of things are super important. And just the engagement, there's a lot of terrible stuff happening in the world, right? But there's actually some things we can do locally to make a big difference.
And as someone who grew up in rural Missouri, and there's very much a lack of internet and technology available, how can we help if that internet? Because Zoom doesn't help. You don't know how to get on Zoom. You don't have a computer. You don't have a smartphone.
Yeah,
you don't have transportation. Those are all the barriers there.
So I think that for telehealth for patients directly, that is definitely a challenge. but there are still clinics and hospitals in those regions. Yes, people have to actually get there, but that could be a hub for information, right? And so thinking in that way, but certainly lobbying to get broadband and internet across the nation. I mean, that's just that.
I mean,
that
in
seems,
Audrain County, they just
Yeah.
closed the hospital.
Yes.
So they're
Right.
gone, that went out, and then the lack of internet.
Yeah, no, that's a huge thing. So transportation and then creating clinics in those areas. You know, we have a workforce problem, but you know, all of these things are tied. So if I think of the state of Idaho, you know, their last MFM left because of the state restrictions, and they are afraid to take care of patients. So all of these things are sort of connected. But I do hear you. Transportation's a big deal. Internet's a big deal. Some of these hospitals were bought out by venture capital kind of people. So they really didn't buy the hospital to serve the community. They got these tax breaks, bought the hospital, shut them down, went, you know, took the money. And so maybe we need different types of healthcare delivery. And those are just bigger questions. What we can offer as WashU is some intellectual thought kind of exercises around this. We can offer expertise. We can offer some technology to hubs. But I think that we have to focus on what we can offer and then really trying to get people locally to figure out what a local solution would look like and how we can help.
I think county health fund.
Yeah, absolutely. Yeah, so she had a question here. Yes.
Regarding cervical cancer and its treatment, what is the data of those that have received chemotherapy versus those that have not in terms of survival rates? Do you have that?
Yeah, well, that really depends on the stage. Cervical cancer comes in many different forms, and early stage cervical cancer is actually treated just with surgery alone. If we diagnose it early, sometimes cervical cancer is diagnosed at later stages of disease, and then we give a combination of chemotherapy and radiation. And even later stage of disease where it's spread all over the body, we now have very good data for immunotherapy and chemotherapy. So that's something that we offer patients. So the types of treatments really depend on the type of cancer, type of cervical cancer, the stage, if it's spread or not, and where it's spread.
Are these initiatives you described that I was aware of it, but I appreciate you sharing them with us. Are these sort of policy grassroots people in the organization, or are these things happening on a broader scale nationwide? Could you touch a little bit on probably related to this funding issues?
Yeah.
Such as probably everyone in this room, they're so
Underfunded. So combination of things. Some of these initiatives are started by our own trainees, our own people who come in, they're doctors, they're training to be a maternal fetal medicine specialist and ask a very basic question. Do a literature search and say, the literature doesn't say, so maybe we need to answer the question. So that's homegrown internally. What's very exciting is we have a community advisory board of former patients, similar to what I described of what we did in Vanderbilt with ovarian cancer. We have a community advisory board of people who delivered or who are advocates who then review some of our research internally. So they're part of our scientific review process going, I don't think that that's really going to work. You know, we're not going to agree to do that kind of study. And then it's what's happening nationwide. But I would say that we have to do more to fund research and train people who are interested in women's health. And surprisingly, 68% of the faculty in my department are women, so it's not a surprise that we're asking these questions. And I did want to say, we are doing some amazing work. Since I've been here, we've recruited 25 new faculty to WashU. So big as the department's been. I want to give a shout out to one of our Professor Emerita, Dr. Diane Merritt, and I will say she's going to be one of two women's portraits, the first two women's portraits we're putting up in our department in early 2024. So thank you all.
Well, can I ask one more question? Last question. Thank you very much. I have an almost 40-year-old daughter, thanks to the program. And
Yay!
Yes,
I am blessed to have grandchildren, twin girls, whose both parents are maternal fetal medicine people in Pittsburgh. And I know they'd be interested. They're right in their chem exams right now, I think. But they would love to get into internships. Should they contact you?
Yes, I will give you my card.
Wonderful. Thank you. Thank you so much, Dr. Khabele. We learned so much from you, and also we'll have this recorded as well. And here's something from our Bare Necessities shop, where Scholars support scholars. We can't thank you enough for all the information. Thank you. And thank you all for coming. Our next lecture is January 23rd. It's Dr. Anna Gonzalez, our Vice Chancellor, and we'll have lunch. We'll look forward to seeing you and have a very happy holiday.